everyone. Welcome to our month of May SimCity rounds. It is such a pleasure for me to introduce our presenter this month. It is Dr. Claire Jones. She's an associate professor in the Department of Obstetrics and Gynecology and also the program director for the Gynecologic, Reproductive, Endocrinology and Infertility, known as GREI, residency program here at the University of Toronto. She completed her Bachelor's of Science and medical degrees at the University of Western Ontario, followed by residency in obstetrics and gynecology and fellowship in GREI at the University of Toronto. She works at Mount Sinai Fertility in Toronto, where she enjoys training future GREI specialists as well as OB/GYN residents. Dr. Jones's main clinical and research interests include polycystic ovarian syndrome, IVF optimization, resource stewardship, and medical education. Dr. Jones strives to provide compassionate, evidence-based care that empowers patients to make educated decisions about their fertility. So, without further ado, I'm going to hand it over to you, Claire. Thank you so much for being here today.
And thank you for having me. So this is really fun. I find simulation very fun. And my kids the other day were saying, "Oh, those slides look cool. Like this looks like fun stuff you're doing at work." And so it was nice to say, "Yeah, it's true. I do get to have a lot of fun at work, and this is fun." So I'm really excited to be able to show you about some of the work we're doing in the fertility world around simulation. And then hopefully make some connections with others of you out there in the simulation world to see if we can make things even better in the field. So these are just my objectives. I want to discuss the current landscape of simulation education and fertility medicine, identify some gaps in simulation training and fertility medicine, also some ongoing projects that we're working on and planning for the future. I don't have any personal disclosures, but our fellowship program does receive funds from EMD Serono Canada, Fairing Canada, and Organon for fellowship-related activities. And I do oversee that fellowship fund and make sure those funds are allocated for educational and research opportunities for our trainees. So the other thing I discovered today is my PowerPoint at work. It doesn't have all the same features as my PowerPoint at home. So I am missing some pretty pictures in here that I had on my slide deck. But I'm going to sort of focus on the two big areas where simulation is helpful in fertility medicine. And it's in patient counseling and in procedural. So I think in OB/GYN, we think about the procedural stuff, but in fertility medicine, we do a lot of counseling. And we have to discuss some pretty difficult concepts with patients. So we've really been trying to work on simulation in this area as well, and not just on procedural skills. So I'll start with around the counseling and how we're doing counseling simulation in general. And what we do is we provide some formal teaching around counseling and then give the residents opportunities for role play. So that's our basic framework for counseling simulation in our field. So some of the lectures we provide some background. I'm sure many of you are doing similar things about how do we communicate effectively? What are some of the things we should be thinking about when we're talking to patients? Are we providing those gaps and opportunities to give patients the opportunity to express what they're feeling? And are we demonstrating that empathy in those interactions, and how do we do that through body language? What kind of language can we use to do that? So we provide sort of some background around these skills, which generally, our residents go, yeah, we know all this stuff. But I think in OB/GYN in general and in fertility medicine, our residents do recognize the importance of communication skills. In our field, we have patients in fertility who are just so desperate to have a baby. They are often very, very stressed. They can often have relationship strain. They want to be pregnant as soon as possible. They're willing to do whatever they can to achieve that. And sometimes, that is an overwhelming sense that can make them not really think about the logic and involved in the decisions they make. So we really emphasize the importance of developing these communication skills. And we do have some sort of formal academic teaching around these skills. And so we open up with like little tips about what are some sort of short familiar phrases you can use to convey, your empathy. What are some short phrases you can use to ask questions about patients' understanding? So we do provide a little bit of framework and advice in the form of formal lectures, and then we go on to give them the opportunity for role play. And my experience in role play is that it works best when I put people in groups of three, and that they have one person gets to role play as the physician, one person gets to role play as the patient, and the other person gets to be the sort of observer who's given a little bit of a framework to be able to observe how the interaction is going so that they are able to give some feedback and provide some pearls to the others. And I find if I do this and just separate them on like a Zoom chat, they don't do it. They really don't engage in it properly and use it well. But when I sort of say, I'm going to come around and see how it's going and provide, some feedback as we go, they know I'm walking around the room, then they really do engage in it. And then I hear, oh, that was really helpful. I didn't realize how hard it was to find the words to say this problem. So that's what we try to do, is have it as an in-person. In my experience, the virtual one doesn't work as well in this for this kind of framework. And so we've had a bunch of different types of communication role play examples. And we also give the person who's being the standardized patient for this a sort of framework of, if you're having this conversation with patients and they say this, then you should get angry, or if you're really not getting to the point, like here's a prompt that you can give them to help them get to the point of the conversation. So we have some basic cases around communication with the patient. This is one kind of around breaking bad news, like someone who really wants to get pregnant, and now you've just did an endometrial biopsy, and this woman has endometrial cancer. And so now she's going to have to put her fertility plans on hold to manage her diagnosis of cancer. So these are real life conversations. We pick these up all the time in the fertility world. So I want to give them examples that are real. They might have had this opportunity to convey this information to patients before. So before they're in that situation, how do they set up the encounter? What are the things they're going to think about? So we do it around communication. We also have ones around conflict management as well. So we have some cases around dealing with conflict with peers, dealing with conflict with other healthcare providers, conflict with a patient, and how you manage that. And so we give them a little bit of, again, a framework ahead of time of how do you provide feedback? How do you manage conflict? What are those sort of steps that you can do? And then afterwards, we usually, as a larger group, will have an opportunity for reflection and large group discussion. So, what has been your experience? What has worked well in the past? Do people have tips for everybody else in the room around what has worked well and what hasn't worked well? And what are some phrases and things people can think about using? So this tends to work quite well and be quite fun as a different kind of activity. Specifically within resource stewardship, we did actually do this as a research project. We looked at communication skills around conveying, having these difficult conversations around resource stewardship within the OB/GYN residency, and the residents enjoyed, thought this was good experience, and they told us in a questionnaire afterwards that they felt more comfortable discussing these issues. I've developed more difficult conversations for the fertility fellows to talk about not just conveying resource stewardship is a really, really big issue in the fertility world, because there's all this stuff on the internet out there saying, if you eat pineapple cores, you'll get pregnant. And, there's all this misinformation out there, and there's a lot of false hope around trying different therapies that there's really no evidence for. And some of them might end up having evidence down the road. They're just ideas, but there's a lot of companies that market these things, that profit off of selling things to patients and to fertility clinics, that actually have no good evidence behind them yet. So I think this is a very important area in fertility medicine for us to train our trainees in, is how to discuss when, when we're it doesn't make sense to give something that potentially has a risk for harm, and there's really no proven benefit at all. And so we've tried writing some cases around some of these things. And of course, this is changing all the time. What patients come and ask me about this month is different from what they asked me about 6 months ago. And there's always the latest fad. So trying to sort of keep these real, and I'll ask the trainees, like, what is the latest fad you've been hearing about? Like, let's practice how we talk about resource stewardship with patients and how we have those conversations. Um, so that's around that. And then we, again, providing a framework for them to be able to evaluate themselves, evaluate each other around is really important. And this comes from our OBGYN study that I also had some colleagues in the resource stewardship world that helped us design this study from OBGYN, but really I still use this framework now to help them sort of talk about, did we provide clear recommendations? Did we elicit patient concerns? Do we show empathy during this interaction, and then confirm an agreement and come up with a plan, for next steps, and then general communication skills. So that's very helpful to use that. We also, in the fellowship world, I also have them. I find in this area, because in this field, we have so many different people involved in fertility care. We have embryologists, nurses, genetic counselors, physicians. And so often when we have adverse events, there are often things that happen that are all over the place, and multiple different factors went into that. And so this can be another area they haven't had a lot of experience, is talking about adverse events of things that happen in a lab setting, or things that, and so being able to communicate these things and talk about how the team works together to provide care for patients is, I think, something that they struggle with a lot. So we're trying to develop more cases around things that are happening within the fertility care in general and how to deal with that. And then the other thing was, we're developing some cases around, what about when you make a mistake yourself? This is a little case example here where the fellow drops the embryo on the floor. Like, these things are rare events. They don't happen often, but the reality is people can trip and fall and drop an embryo. Like, the dish can tip off the edge of a counter. Like, these shouldn't happen, and there should be balances in place so that wouldn't happen, but these things can happen. And so how are you going to have this conversation with the patient when you're the one? And when are you going to have the conversation? Like, how soon should you disclose it? So we try to give these kind of examples, and then we open it up, like, for discussion, and give them the opportunity to role play around that. So that is the main area of counseling simulation we're doing, is around this role play. Of note, we did have a longitudinal study. It's still not published yet, but the manuscript is almost done, looking at a longitudinal communication curriculum within the OBGYN residency, where we approached at least 25% of the academic half-day speakers and said, how can we take your topic that you're presenting on, which is usually some medical expert topic, and integrate some communication teaching in it? We gave them examples of how you can use role play, how you can provide, case examples, and asked them to integrate that. And then we looked at EPA scores specifically within the communication part of the EPAs over that time frame where we did the intervention. So it was over a year that we intervened on 25% of the academic half days, where we tried to get educators to include some teaching around this. And a lot of it was role play, because that was one of the areas people thought was amenable to teaching communication skills. So that was very exciting, because people actually did show a bit of an improvement in their communication skills on their EPAs. These are general EPAs. Although, and of course, those skills developed over time, as we know, as the more senior residents develop more skills in communication compared to the more junior residents. And so this is coming as a publication to come, but it's not specifically simulation, but a lot of it ended up being around role play. So that's sort of a little bit about the counseling simulation that we're doing within our field. I'm going to then talk to you about procedural simulation and how we have some formal instruction also by opportunities for actual practice. So there's quite a bit of stuff coming out now around low fidelity simulation within OBGYN, particularly around laparoscopic skills, catheter insertions, vaginal surgery, abdominal surgery, fetal surgery. There's not as much in the fertility world. But a lot of the stuff that's out there in the OBGYN world is also translatable in different ways. So for instance, this one around Vary's needle insertion, we ended up have used a lot of the tools and that were published in these papers around, what sort of equipment you can use. And develop that for our own models that we're using. So we kind of looked at the literature, thought, oh, actually, that makes a lot of sense. Okay, maybe we'll use some of these some of this equipment as well and see how we can translate it to some of our other specialized areas. And so if we look at that model too, this can be translated in many ways for other different procedures that we're doing. I just wanted to give a shout out to some of my colleagues in general OBGYN who've done a lot of work around teaching vaginal hysterectomy. This is one of those skills that many residents don't get as much exposure to, and they use some really simple tools from Dollarama, to be able to put together a model that they can use within the general public framework to help teach the steps in vaginal hysterectomy. And a group of us presented recently at ICRE. Actually, I couldn't make it, but my colleagues went and presented a little workshop on how to make a low fidelity simulator. And so Dr. Chekhov, who designed that vaginal hysterectomy model, was there. Also Dr. Rashevsky, who was presenting some of the other hysterectomy, hysteroscopy, laparoscopy skills, and Dolly Carroll, who was one of our former residents. And they really had people building their own little models. They said, what do you wish you could make? And then they had and they gave examples of some of these models that had already been made at U of T. They provided a whole bunch of equipment from Dollarama, a lot of big shopping bags worth of stuff. And then people basically built their own little models. And what they built was a variety of different things. We have a lumbar puncture model. We have here a bone marrow biopsy and a pediatric gynae exam as well. So these were some of the models that people built at ICRE. And we're able to demonstrate to their colleagues there about how really it's pretty simple to put some of this stuff together. So I thought that was pretty cool. In terms of fertility, what we're doing is there's some already pretty fancy models out there for transvaginal ultrasound and transvaginal ultrasounded egg retrieval. There's not a lot of published literature on it, and the published literature is not that exciting. And I think what we realized in fertility medicine is, one, you have to know how to do a transvaginal ultrasound, and you need to know how to do them well before you can do transvaginal ultrasound guided egg retrieval. Fortunately, in our field, we do so many transvaginal ultrasounds every day that developing these skills in the real world is actually quite easy to do. So simulation for transvaginal ultrasound within REI is not that important because they get very good exposure very early on. And we have lots of patients who are used to coming in for lots of transvaginal ultrasounds who are actually fairly comfortable having our trainees learn on them and who are happy to teach them. Okay, you didn't really insert that the nicest way. Maybe next time try this. So we do have a lot of patients who are very helpful in teaching our trainees. And once they know how to do a transvaginal ultrasound, then the transvaginal ultrasound egg retrieval is not that hard. So in the published literature that's out there, particularly in North America, it really doesn't show a lot of benefit to simulation training for this. This is our primary skill. that they need to develop, but it does show some reduced anxiety and increased confidence among trainees by having done some simulation training. In truth, we at U of T every year, we have these nice models that are provided from some of the pharma companies who are happy to come let us use their model. And at the end of July, early August, once they've gotten their good ultrasound skills, then I have them come play on one of these pickup simulators with their beautiful images so they can see what it's like. It's I think it's fun for them. They can do it many times over in a very short period of time so that they get sort of comfortable and get the speed that they need to be able to do these procedures more quickly. It's not quite the same as doing it in real life, but I think they enjoy this opportunity to practice on a model and not have the stress of learning on a real patient. And so we do use these simulation models that are out there. In the United States, they use them a lot more, although there's not that much published literature on it, and probably because it's a different world in the States. A lot of people are paying for fertility care in Canada. There's both private and funded IVF, but generally our patients, are happy with trainees involved in their care. Whereas we find in a lot of the U.S. programs, the patients who are paying out of pocket ask to not have a resident involved in their care. And so often they can do 3 years of fellowship training and only do a handful of these procedures independently. And so they really rely on the simulation training more, whereas I think we just have a different climate in Canada where patients are more willing. And the other thing is in our field, these are OB-GYN residents. These were people who were doing complex gynecologic surgery before, coming and doing fertility fellowships. And so doing an egg retrieval is really not that hard if you have the ultrasound skills. And, doing a complex endometriosis surgery is a much more difficult skill to develop. And so I think that's probably where it comes from, that this is not as valuable. But I do think it is valuable for the rare cases. And so one example is transabdominal oocyte retrieval. So there are some cases where the ovaries are not accessible through the vagina. Usually they are. They're really close and easy to get it, and that's the best approach. But for some women, either people with really large fibroid uteruses, people have had transposition of the ovaries because of previous radiation therapy, or whatever reason, if their ovaries are nowhere near the vagina and up near the anterior abdominal wall, we sometimes need to take this approach through the anterior abdominal wall. And it is harder to do because you've got more layers to go through. Going through the vagina wall is like with a needle, vagina is pretty flexible. It's a relatively easy procedure. But going through the anterior abdominal wall is more challenging. And they often haven't had very much exposure to this. They might get 1 case a year, 2 cases a year of these in training. And so how do they feel confident? We always find it funny. We get a lot of referrals from other fertility clinics across Canada for patients for transabdominal egg retrieval. We always think it's not that hard, like if they could do a transvaginal egg retrieval, they should be able to do a transabdominal one too. But obviously those physicians didn't have the opportunity to practice in training and didn't feel comfortable. So we want our trainees to come out feeling comfortable. So first of all, we provide a little bit of background. A couple of my colleagues put together a video that's being published on transabdominal egg retrieval. This was a real patient case, and so there's a nice little video you can watch that goes through the technique, and it was a real patient case, and they actually have nice animators going through, what's involved, and so we can show them this as in the teaching too, like this is a case, this is what you should be thinking about. Here are the risks and issues. I'm just seeing there's something in the chat there today.
I just said I love the pun.
Okay, yeah, it's a cute title for sure. Yeah. So we can show them this video first, and then we have to give them the opportunity to practice before they're doing it in real life. Because it's harder to do. So this is a model. Dr. Justin White is a fertility doctor actually at the University of Ottawa. And he developed this nice model and has tested out on his trainees in Ottawa. And so we've adopted it as well because we're like, oh, this is great. Like, let's use it. So basically, he just takes a bunch of balloons, fills them up with the fluid. So this is supposed to look like the stimulated ovaries. We use the water is tinted with food coloring. Okay, so you can kind of see them more clearly that you're getting the fluid out. So it also has that appearance of like the follicular fluid when it comes out. It's got a little bit of color. And then we like layer them all up like this, and then place them in a basin with a thin layer of gelatin. Okay, so that the gelatin can be used for ultrasound, because this is the key. You need to be able to do sonography or ultrasound for this experience. So then we fill it up, and this is kind of what it looks like afterwards. And then this is the transvaginal ultrasound probe. So transabdominal egg retrieval can be done either with an abdominal probe or with the transvaginal probe. Many fertility clinics, because they barely do any of these, will just use the transvaginal probe and not have a specific transabdominal probe. So there's a nice needle guide attached to the transvaginal probe, so you can, with a biopsy needle on the ultrasound, so you can see that you're going in the right place. So you've got these sort of dots that show you which way your needle's going. And here we can see the needle popping in through the gelatin that's sort of like the pelvis, the pelvic fluid, and popping into the balloon, and then you can suck the fluid out. And so it's kind of a neat low fidelity model. Like, it's easy to put together. It doesn't last forever. You need to, replace the gelatin over time. So you do need to, and the balloons, obviously, once you've punctured them, you need to replace them. But it's actually fairly easy to put this together and give them the opportunity to have this practice. The other thing we find in transabdominal egg retrieval is because the anterabdominal wall layers are a little less flexible than the vagina, we have to teach them that they might need more than one puncture to get into the ovary to do that. So at least with this, they can practice moving, their position and trying to keep it at a 90-degree angle, the ultrasound probe, so you can minimize the distance through the fascia and all the other layers of the anterior abdominal wall. So he did a little study of his trainees, of which he doesn't have that many. So not a lot of people here. And so I think what we're trying to do is going to see if we can sort of bring this across Canada, so we can give the opportunity for other people to try this out and see if it's actually beneficial or not, because it's hard when you've only got a few people to try it out on. But yeah, I think it's a fun little tool, and so we have use that ourselves. And now what I'm trying to do is build a model for transmyometrial embryo transfer. So, we published a nice little video on transmyometrial embryo transfer. So what this is so when a patient's had a history of cervical cancer and they've had a trachelectomy, so the cervix is removed and now the uterus is attached to the vagina with a stitch, sometimes we can't get into the uterus. Occasionally we can, like there's a little passageway and you can get in there. But the whole point of having the cervix removed was to give these women the opportunity to be able to carry a pregnancy in the future. Otherwise, the treatment is a hysterectomy for cervical cancer. So these are women who really want to get pregnant. They want to have babies, but sometimes it's so scarred up from the surgery, particularly if they had a little bit more advanced cancer, that they were right on the margins, and we just can't get into the uterus. And so we know that we can get in with a needle through that sharp, through that dense scar tissue. And this is a technique called like using a Tawako catheter. It's a Japanese technique that's being described. So there is equipment to do it, but like we're used to using soft, flexible catheters to sneak through the cervix. Our trainees are not used to using a sharp needle and then getting it into the uterus and getting into the right place so that we can place an embryo in there. And so this is a challenging one because we don't have that many patient cases. We have maybe one a year, sometimes one every 2 years. Do we really want them doing that one patient that comes every couple of years as their first opportunity to try? So what I'm trying to do right now, and I was telling Dr. Abdul, I was trying to get this model ready for this presentation, but it didn't really work, the latest iteration that we made. but I'm trying to adopt that transabdominal egg retrieval model, but I need something to make that dense experience so that they can feel that pushing through, and knowing that the uterus may move a bit when they push through with the needle, and being able to move with that to get it into the right place, but under ultrasound guidance. So trying to find the right medium to be able to do that is what we're working on. So we got the videos for the teaching, but now what we need is the actual model for them to work on. So that's a work in progress. The other area of fertility medicine is embryology simulations. So we at U of T, we have our embryology master's program here. It's the only master's of embryology in Canada. That was the first program. And so we're also doing a whole bunch of cool things here that we weren't doing a few years ago. And so first of all, there is a bunch of commercialized simulation training in embryology in general. Like this is one around ICSI, so where we inject sperm into eggs, and teaching our embryologists how to do this technique so they can have the opportunity to practice on simulators. So this is like a virtual reality headset where you're basically trying to practice, because you have to have very steady hands, be able to pick up the sperm with the needle, which means you have to whack the tail, pick it up with the needle tail first, and then stabilize the egg and inject the sperm into the egg. And it's all under a microscope, right? So these are difficult techniques. So there is already a bunch of, simulators out there in this area. But we also have a sim lab at U of T, where our embryology trainees get the opportunity to use. We have some bovine tissue. We have eggs and sperm and embryos that have been donated from patients who've finished their family, or these were not transferable embryos, that give them the opportunity to practice some of these techniques, as well as biopsy. And then my colleague, Dr. Jenny McKelly, started this program, our ovarian tissue cryopreservation program at U of T, and Madison Erb is also one of our former Masters of Embryology students, and now one of our embryologists at Mount Sinai, who's our main person in this program. And they created a nice little video of how to do this technique. And it's important to basically cut the tissue the right way and cut it into small pieces that can be frozen easily, so that we can use them in the future if someone wants to be able to get pregnant in the future. So this is for pediatric oncology patients who are going to have cancer treatment that will likely make them sterile, who might, as we're seeing a lot of pediatric cancer patients now surviving into adulthood, they want to come back and have a family. And if we've got some tissue frozen, we have the opportunity to transplant that back potentially either to them, or if things evolve in the future and we're able to make oocytes develop in a lab, that's something for the future potentially as well. So they created this nice little video, and they teach this in the lab to all of our Masters of Embryology students using bovine tissue. So we get donated bovine ovaries, and then they get to practice this technique, which is really cool stuff. So right now, our next steps into fertility is that we're doing a little study right now. We're starting with a needs assessment. We're trying to develop a toolkit for some of the fertility simulation stuff. So we actually just got REB approval yesterday for this project. So we're planning to send out a survey to program directors across North America, so through the United States and Canada, asking them what simulation training they're already doing in fertility medicine. We've given a list of questions about, different areas that we think they might want a toolkit really for doing simulation training in this area, and then, opportunity to provide open-ended feedback about what areas they would like. And what we want to do is develop sort of some models, including some of that counseling stuff, a role play in some of these difficult discussions, and then also, some of these rare types of procedures, and provide them with the instructions how to develop, and create this yourself, so you can give them the opportunity to practice these things. So that's our next step, is just sort of see what people want in the toolkit, what people are already doing or not doing, and what they would find helpful. And in the meantime, we're starting to make some of these models, and we'll test them out on our U of T students first, and see how it goes from there. But some of them are already kind of in practice. So we just haven't formally studied all of them that much at this stage. And it's hard because this is a small field. Like there's usually 9 GREI fellowship spots each year in Canada. So, we don't have a lot of trainees to run large studies on. So a lot of this is going to be, we're not going to be able to see significant differences in our trainees. But I think this is a start, in this field. So I put up some references there. I didn't make tons of slides because I wanted to have opportunities for questions and feedback. So I'll stop my share.
Thanks so much for that, Dr. Jones. It was a very thorough presentation and gave an excellent overview of all the exciting simulation work that's happening in GREI. I appreciate that we may not have other GREI specialists here, but I wanted to get the ball rolling, and Lisa, who is one of our pioneers in surgical simulation, has joined us, and she mentioned into the chat, have you tried a hollowed eggplant?
Yeah. That's a good point. A hollowed eggplant. No, I haven't tried a hollowed eggplant. That's a good point. Yeah.
You should try these small Italian ones, and you
Uh-huh.
actually use a morselizer in order to take your internal core out. But I think the durometer of the skin of the eggplant, sorry, will mimic maybe the pressure needed by the needle to go into the uterus with a little soft tissue. I have this in my head, it might work.
No, that's great. I always find it funny, all the vegetables that come across your lab there.
Yeah.
I'm like, what's the latest vegetable? Uh, no, that's a good point. I think what we need though is something a little tougher. Like sometimes that scar tissue is quite dense. Um,
Yeah, so maybe with that you could put a even like leotard over the eggplant or some form of plastic bag or something like that that would maybe or even I dare say paint on a hydrometer silicone.
okay. Okay.
That
No,
might work. And for your just as a tip for your ultrasonography, if you want to increase some of the more I don't know how to say the word, but a tissue-like appearance in your gelatin, put sawdust. And what it does is it gives it a really realistic look as ultrasound, as opposed to just looking like a plain picture. With the eggs, you get that tension of the look in it with the sawdust.
oh, thank you. That's great advice.
Welcome.
Okay.
We've created a community of practice here.
That's perfect.
Uh,
I selfishly thought that I'll come and talk and hopefully someone will give me some good tips too.
we make it all your dreams come true. I um I wanted to ask a question. Did you have anything else, Lisa, before I
I missed a little bit of the beginning, but I'll try to think of some more things. If you're having any struggles with model making itself, and you want to send me a message, please feel free to, because sometimes something will just come up that we've tried before ourselves, and we're happy to pass on.
Great, thank you.
Thanks, Lisa. So my question was related to the earlier part of your presentation because I'm a Jerry psychiatrist and a medical director of the CAMH Simulation Center. So we do a lot of non-technical skill type communication. So sorry, simulation. So we have a lot of interest and are invested in the Breaking Bad news. So I was excited to see that you opened with that one. We have one here at CAMH that we built in response to our quality of care committee findings where we had some incidents, safety incidents that required us to upskill our staff in delivering bad news. And so we used the Cleveland Clinic's HEART model. Hear, empathize, apologize, respond, thank. And then we built out this simulation, and now we're trying to create like an AI avatar that they can practice with. Because right now the original simulation that we built was with a standardized patient that they were practicing with. So I was just wondering if you could give us some more details around your Breaking Bad News simulation and how you're delivering it.
Yeah, it's a good point. I mean, right now we're using the trainees as the standardized patients and giving them like the description of this is what, this is what going into this interaction. This is how you should react based on how they say, how they disclose different things. So, um, you can become upset, you can become like, so we're trying to make it like realistic that people might, behave differently in different
Mhm.
situations. But we're not actually using a standardized patient or AI for that right now. But that's a good point. Tell that if you have sort of some AI or that gives them an opportunity to go back and practice again, right?
Yes.
Do it over and not just within the framework of an academic half day time, which is how we have it at the moment.
Yeah. But I mean, even so, you've experienced it enough times that I'm sure you can replicate what the conversation should entail and what they should cover, right? So the role play is still going to be effective in my estimation if you have your faculty expert debriefing afterwards and helping them to sort of say the right words um,
Yes,
and
yeah.
convey that empathy. That's great. Anybody else had any questions for Dr. Jones?
Yeah. Hi, it's Stephanie. I work with Petal and at the Center for Addiction and Mental Health. So yeah, I'm also interested in the kind of first part that you shared, right, around the communication. And just to add to Petal's comment around the SPs, something else we do in mental health is have lived experience advisors too participate, and they actually do a lot of training with the SPs, and sometimes even if they're available, and I know this is, there's implications for resourcing, et cetera, but it's just a really helpful way to hear, like, and I think the purpose of those simulations around kind of understanding the impact of the news you're providing and being empathetic. And so it's been really useful for us having the patients there. And I just wonder whether you've considered doing that with the fertility patients you work with.
No, that's a very good point. And we have patients who are highly engaged in this area who would probably be very happy, to provide some feedback in that sense. So that's a very good point. No, I haven't thought about engaging patients specifically around that training. Thank you. Good, good point.
Yeah, so Lisa would know that we are working with surgical foundations. So Jory Simpson, who's published a lot on humanism and surgery, connected us with a surgical lived experience advisor, and so that we got a grant and we got the LEA to join the simulation and to sort of fill out a communication assessment tool and give feedback to the residents on how they felt um, the interaction went. So it was pretty rich and interesting. And we're trying to embed our lived experience advisors in all the sims that we built in psychiatry anyway, because we realize that it really makes things richer um, overall.
So
But
do they actually come or they just help provide they train the standardized
so they
patient?
train the standardized patient, they look over the scenario, and then on the day of, they come and they can either be in the room or they could be watching remotely, and then they can give the faculty feedback. It depends on how you want to configure it.
Yeah, that's great. Right.
Yeah.
Okay.
Any other questions for Dr. Jones? Comments, kudos? I'm really shocked that there's only 9 GREI specialists across Canada.
Sorry, training
Training
spots, not
spots,
specialists,
yeah.
training spots each year. Yeah, exactly. So yeah,
Yeah, it
no.
was it was quite an interesting and much needed. Lisa, you're saying something?
I can't be muted. No, sorry. I just wanted to add maybe a comment. Just, I wondered, first of all, if you're engaging any of we just had a simulation summit, so I've realized how much, how many researchers are out there now and, looking to support many of the projects that maybe reaching out to the likes of Ryan Bridges at St. Mike, or yeah, St. Mike's and Stan Hamstra, maybe to support some of the ambitions with the projects you're putting together and then and help maybe with research grants and the likes of. And then the other thing was with the models that you're making, I'm just wondering, and I've thought about this for many models that we love to make from scratch, actually bringing them in situ to the actual patient site in which the expert is performing, but alongside in real time, the trainee has the opportunity to utilize the created model and do it at the same time and have it videotaped just to see where diversions are within the model, the trainee, and the likes of. Just, I don't know if anybody's ever studied parallel universes at the same time.
Interesting. No, I haven't thought about that.
Yeah, I don't know what made me just think of it, but for some reason, your pictures with the uterus and things going on, I thought, oh gosh, wouldn't it be great to see the expert do it at the same time as a trainee is doing it, and then be able to compare the two in real time through a video feed of some sort, and be able to get maybe, feedback, better verbal feedbacks on haptics, because that seems to be where, with a lot of the models, it's difficult to translate haptic because it's in the expert's mind, but to translate it then to a model or to the learner is not easy. I know AI and computers try to do it. They're okay. But I still think that the human touch still has its place.
Yes, you're absolutely right. That is often the hardest part of the model is that tactile sensation, the awareness of what it's supposed to feel like where, and yeah, and how to communicate that.
So, if we don't have any more questions for Dr. Jones, I want to just give you a heartfelt thank you for all the exciting simulation work that you're doing in your space. It's really inspiring the rest of us. And we would love to connect with you at any time if there's an opportunity for synergy, or if you're just curious about any way that we could help support your work further. And we hope to hear more from you in the future when you
Well,
get that new model online.
exactly. That's right. Well,
Thank you so much again for making the time, and thanks everyone for coming today.